So today we're going to talk about the impact of epithelial thickness mapping in corneal refractive surgery, at least some of the aspects of this. I have a financial interest in this in that I've been a consultant for Carl Zeiss for a good 16 years, but mainly because I started measuring epithelial thickness before anybody thought it was of any interest in 1991. My work was progressed into a commercially available high-frequency ultrasound device that produced, I would say, all of the knowledge that I currently have about this, and I would say the vast majority of the material I'm going to present is as a result of the ultrasound work. But I'm going to be able to show you how now we have access to optical coherence tomography machines that can give us a lot of the information that we would get by ultrasound without the necessity to use a water bath. Those two technologies are not mutually exclusive. I need to use both in my clinic. We scan about 10 to 12% of all of our patients get both ultrasound and OCT for various reasons. But in general, OCT does a very good job of the major and simple parts and simple applications in refractive surgery. I'd like to, however, talk just for a second about the measurement of epithelial thickness, because it's something which is now inherently obvious to most of us. Although when I first measured the epithelium in 1991, I was told that it had no applications. There was no point in doing it. So if we look at the timeline of epithelial thickness measurements, when I got to Jack Coleman's lab in 1991 in New York, and I was working with Ron Silverman, Mark Rondeau, they had high-frequency ultrasound probes. And I was working on a glaucoma project for them, but I was scanning a rabbit cornea. That was in formalin, and I was scanning it one evening and found that I was scanning all the parts of the eye and got some scans of the cornea and saw that I could see two lines at the front, and measured this as 33 microns and looked up that the rabbit epithelium of the cornea is about 30 microns thick, and I thought, wow, this is great. We knew that we could measure things with about 1 micron precision at 60 megahertz. And so I decided to try and make maps of these multiple scans. And so within a year or so, I'd managed to do a bunch of rectilinear scans and join them all up on a Macintosh program that would plot things in 3D on a color scale. And I made a 3mm map of the epithelial thickness of a cornea that had a central island, patient that had had surgery during phase 2 of the PRK trials in the US FDA trials, and a couple of normals as well. And I published this in Ophthalmology. That map that you see there with the 3mm diameter took me 6 months to analyze the data and then plot it. So it was really quite a laborious task. Let's move forward many years later. We developed a new scanner. After my residency, I went back to Cornell between 96 and 97. We built a mechanoset type device that would move the probe in an arc fashion, so that instead of just getting the central part of the cornea through rectilinear scanning, we were actually telecentrically following the curvature of the cornea, and therefore we were able to get basically the whole corneal diameter. And I published in 2000 in the JRS a paper showing how you could measure the cornea before and after LASIK and show the changes in the epithelium, changes in the residual stromal thickness layer and the three-dimensional aspects of that. But still, there was, apart from me, there was no one interested in doing this. Because of the PRK and the Hayes studies that had to go on during the 90s, though, confocal microscopists were looking at Hayes measurements with confocal microscopy. And of course, with a confocal microscope, you're able to measure epithelium. Of course, you can only measure it in a very small area, and it's a rather laborious measurement, but it can be done. Torsten Müller-Pedersen, who was with James Jester at the time in Dwight Kavanagh's lab, they were looking at PRK changes after epithelial changes after PRK also. Shortly after that, it was shown, a paper came out on using OCT to measure epithelial thickness. It wasn't until 2008 that these multiple multimeridional scans were turned into a map, the way I had done in 1993 with ultrasound. And so the first paper on OCT epithelial mapping came out in 2008. And by 2012, OptoView, who had obviously excellent foresight in realizing that this was clinically something that was going to be of use to the future of all refractive surgeons, not just crazy researchers, they developed a module within their RT-View that could measure epithelial thickness within a 6 millimeter zone, and this basically kick-started the popularity, I would say, which is still at its infancy, but the popularity of measuring the epithelium. So if we go now to 2016, we actually now have a whole market, and there are multiple devices now available commercially that are OCT based, that most of them, of course, available outside of the United States, which will measure epithelium and map epithelium. But most of the OCT data I'm going to show you here is from the RT-View, from the OCT, actually from a modified RT-View that got a 9 millimeter optical zone. And now the Avanti, which is a better resolution version of the RT-View, is the commercially available epithelial thickness map that is the latest iteration, and the one that I would recommend people to get if they're in the US, because that's the one that's FDA approved and available and purchasable right now. So in this lecture, what I'm going to do is I'm going to go through three sections. The first, I'm going to talk about, the epithelial thickness profile of a normal cornea and why it looks like that and how it varies. Then we're going to talk about how we can use our knowledge of epithelial thickness profiles in the normal to distinguish a normal cornea from a keratoconic cornea in cases where the topography or the tomography is not sufficient to give us a diagnostic decision. And then I'm just going to mention some of the rules of how the epithelium behaves over irregular corneas as an introduction to beginning the diagnostic process in a therapeutic refractive surgery situation, a situation where there's irregular astigmatism or a corneal irregular astigmatism, a problem, an optical problem, because that is the gateway to understanding how to correct corneal refractive surgery complications. And after being someone who's been around epithelial mapping and layered anatomical diagnostics of the cornea since I started in refractive surgery, I can say that once everyone is using cross-sectional imaging and mapping of individual layers, the number of complications that will be left unrepaired is going to go down dramatically. It's not going to be a question anymore of having to refer patients to super specialists who do repair work. I think everyone is going to have access or feel comfortable doing repair work once they understand how the anatomy changes in a complication. Because I think a lot of the issue that has been over the years of people not feeling comfortable repairing complications is just that you don't have a mental image of the anatomical issues, and all you have is a topography. It doesn't really tell you much. But we'll go over that. So, the normal epithelial thickness profile. Well, before I started measuring it, every source and every resource that I could find on the epithelial thickness profile of the cornea said that it was an even layer of epithelium over the cornea that was about 50 microns thick, and it talked about the 5 different stages of cuboidal cells becoming wing cells, becoming squamous, and getting shed off. And it described basically histologically what was found. But there was only this one publication from Brian Holden from the early 80s, which he'd used an optical picometer with a magnification on a CCT screen to measure epithelium. Apart from that, there was no measurements of epithelium. And there was certainly no three-dimensional measurements with 1 micron precision. So perhaps a little late in the game, 2008, I could have published that probably 10 years before, but you know how things are. I finally got together and published a large series of normal eyes. And what we found was when we divided the epithelial maps into right and left eyes, and let me just orient you here. This is a square grid that's 10 millimeters by 10 millimeters, and we have here an epithelial thickness profile where it's thicker is red and thinner is blue at the bottom. And this scale is, for example, as you can see, going from 51 to 60. If we separated the epithelial thickness profiles of right and left eyes, we got slightly different patterns that were in a mirror fashion. But the important thing about the pattern, the average pattern, was that there was a difference between the superior and inferior mean thickness, about a 6 micron difference from top to bottom. And there was about a 1.2 micron difference from nasal to temporal. Now, this was true for either left or right eyes and in a mirror fashion. So the speculation that I had way in the early times, and I wrote this in the discussion of my 1994 paper in ophthalmology, was that the eyelid forces must be what is controlling epithelial thickness profile, because we obviously blink 10,000 times a day, and our eyelid comprises of a semi-rigid tarsus in opposition to the corneal surface, and there is eyelid tension. And so, you know, thinking just in Newtonian terms, if the epithelium is growing out all the time, then the only way that it can stay in steady state is if the growing out force is equaled by the pushing in force. That would create a steady state and a steady curvature, and obviously the curvature of the cornea is maintained to within tenths of a millimeter radius, because otherwise glasses wouldn't work, right? You wouldn't see the same on Monday morning as you would on Friday at 3 in the morning after 22 vodkas. So the maintenance of the outer curvature of the epithelium is extraordinarily tight, and it must be because of this equal and opposite forces. So as we blink, two things are happening. One is, of course, the upper lid has more contact than the lower lid, and so there's more chafing or more pressure, more squashing of the epithelium superiorly. And this equal and opposite forces concept will mean that whatever the shape of the tarsus and shape and force applied by the tarsus is, that will determine the outer shape of the epithelial thickness profile, because of course it's continuing to grow out. It also actually explains, as an aside, it easily explains why astigmatism goes from being with the rule when we're young to against the rule when we're older. And that makes sense, right? If the eyelid is squashing the cornea like this because it's tight, as the eyelid relaxes as we get older, so the horizontal cylinder is diminished, the effect of the eyelid on the epithelium. So that actually fits what we observe in the normal. So how do we prove that the eyelid forces are really what are affecting the epithelial thickness profile? Well, one way of doing that is to substitute the eyelid with a contact lens that doesn't fit well and wear it overnight and see what happens to the epithelial thickness profile. So we put an Ortho-K lens into the eye and go to sleep. The flat central part is going to squash the epithelium down centrally and redistribute it towards the periphery, and that's exactly what we see with Ortho-K. Published this many years ago. This paper is cited all over the place in the optometric community. We measured epithelial thickness profile before and after, and the next morning after the lens had been in all night, in the right and the left eye. And interestingly, the left eye didn't have a well-centered lens, and the epithelial profile change was decentered. So it's a great little experiment in a sample of one person where we could see that substituting the eyelid for a different anterior surface would produce changes in the epithelial thickness profile. There we see. Now in the 90s, it was starting to be noticed by a number of groups using optical pachymetry and myself with ultrasound, and I mentioned the confocal microscopy, that the epithelium changes and gets thicker after myopic ablation. And this was being found pretty much all the way around the world, but we were the only ones to be able to do a large area high precision map. And what I showed was that the epithelium became obviously thicker in the center, but it became thicker in the center and progressively less thick as we went out towards the periphery. I also showed that it was actually, the epithelium became thinner in the periphery after a central ablation. We later correlated this epithelial thinning to the fact that the stroma was thickening in the periphery. And we were noticing this right around the time that B.J. Dupes was doing his PhD with Cynthia Roberts, and they were showing that PTKs caused peripheral thickening of stroma. So all of this was fitting together. The epithelial thinning was a compensation for the zone of stromal thickness change in the periphery. I published papers showing that the amount of power shift caused by this epithelial thickening in the center was more significant in low myopia than high myopia, which is the opposite of what you'd expect. But it's understandable if you think that the epithelium can thicken, of course, but then it can only thicken to a certain amount and then it won't thicken anymore. So here's the curve of the low myopic group. You can see that it thickened quite a bit in the center, but obviously less in the periphery. But as you go to moderate and high myopes, the central part of the cornea, the central 3 millimeters, rather than changing in a lenticular fashion, was changing more in a parallel fashion because the epithelium was already maxed out at that level. And so the power shift caused by epithelium is less significant in high myopia than it is in low myopia. Interesting. We also looked at, for example, the epithelial thickness profile after hyperopic LASIK. And this was a big piece of work that led to a number of discoveries that led us to be able to do much higher hyperopic treatments than was generally thought to be safe, because we would know way in advance of creating a problem when to stop doing ablations, so when to stop doing enhancements. So in this study, we had 65 eyes with at least 3 months follow-up. They were all treated in 7 millimeter zones. And here's the mean epithelial thickness profile of the whole group. And you can see that the epithelium was quite thick in this ring where the ablation occurred. But of course it became thinner over the center where the cornea was steeper. And this pattern of epithelial thickening, this donut pattern, was obviously typical of a hyperopic ablation, and it's the mirror image of what you'd expect in a myopic ablation, where the center becomes thicker. It demonstrated that the epithelium was changing exactly in the 7 millimeter zone that was intended to be the optical zone of the laser, and we showed that, based on how steep you made the cornea, so the thinnest point of the epithelium would become thinner the more you steepen the cornea, but the more you steepen the cornea by LASIK, the thickest part of the epithelium would be. This is logical, but unexpected. But what was really interesting was that when we looked at individual eyes, we found, for example, that you could have a relatively flat cornea that already had epithelium that was very thin. So mean epithelial thickness is 53. Epithelium starts to break down once it gets down to about 25 microns. And, it's just too thin at that point. We know this from keratoconus, right? As a keratoconic cornea becomes more and more steep, eventually the epithelium breaks down and you get the scarring. So here's a cornea that was quite flat after a hyperopic ablation, but the epithelium had already become quite thin. That cornea, even if it was a flat cornea, could not be enhanced. You can't go and steepen a cornea that already has thinning down to the limit. On the other hand, here is a cornea that had a keratometry of 50, but the minimum epithelial thickness was 44 microns. Well, there's plenty of epithelial thinning to go on that cornea. So actually, if that cornea needed a +1 enhancement, it actually would be possible to do that. So, well, likewise, here is a cornea where the epithelium was too thin at 49 Ks. So, in other words, it's not really the Ks that determines what is safe to do on a cornea, hyperopic ablation-wise. It's the epithelial thickness profile at the minimum point. And the Ks is just a proxy for kind of knowing what the epithelial profile is doing. Now that we can measure epithelial profiles directly, there's no point in measuring the Ks. In fact, we don't really look at the Ks anymore, other than just to document them when we're doing hyperopic ablation enhancements. So, essentially what we're saying is that hyperopic LASIK, which has a very mixed reputation in the ophthalmic community, it's probably because we've been using the wrong safety metric. We've been using Ks as a way of predicting what we can treat and when we can retreat. And of course, epithelium is by far the best source of information for epithelial thinning relating to central steepening. So anybody starting to use epithelial mapping will find that they're able to do much, much higher hyperopia much more safely. Of course, one of the keys of hyperopic LASIK is to use larger optical zones, because then the rate of change of curvature on the stroma is much, much less severe, and therefore there's less epithelial thinning. We'll come to why that is soon. In our paper, where we had 2 years follow-up, treating hyperopia from +4 to +7, this is almost 800 eyes, we had 76% 20/20 or better, and that's about what you get with IOL surgery from +4 to +7, and we only had 0.4% loss of 2 lines, and that was because we were able to not do enhancements on patients who had epithelium that was too thin, and so we didn't get into a corner during this study. Although we did discover something else, which was diurnal fluctuation of refraction post-hyperopic LASIK, and found that it was related to epithelial thickness profiles that were shifting due to eyelid tension that was causing flattening overnight. So that's another paper, but we can talk about that another time. Okay, so let's go to really what would be the major reason to have epithelial thickness profile measurement in an average general refractive surgery practice, or even a general ophthalmologist's office of someone who does LASIK, because it's all to do with keratoconus screening. And this was really a diamond in the rough at the beginning, and now it's become a well-polished, huge 3-carat diamond. When we consider what the epithelial thickness profile looks in keratoconus, I mean, you would, without showing you would already imagine what it's going to be. But let's just think about it in theory. So in a normal cornea here, I've drawn the front corneal surface, the stromal surface, and the back surface. And of course, the epithelium is here in the shading. In a keratoconic eye, of course, there is forward bulging of the front and back surface. The epithelium tries to compensate for the bulge and becomes thinner over the bulge. But what we learned by mapping was that the epithelium became actually thicker in a ring around that bulge. This would mean that in early keratoconus, when the back surface would bulge slightly, but the front surface would only bulge slightly, and the epithelium was able to fully compensate for the anterior stromal surface shift, topography would not pick up the inferior steepening because it's fully compensated for by the epithelium. And so in cases where there are very small asymmetric back surface concerns, being able to distinguish whether that's noise from the normal population or actually a cone the way you do that is by seeing coincidence of the thinner epithelium with the position where that back surface is eccentrically elevated. What's even more interesting, actually, is that most topographies that are classified as keratoconus turn out not to be keratoconus at all. And you can prove that they're not keratoconus because whatever that anterior surface bulge is, you can prove that it's correlated to thicker epithelium in that region. You cannot have thicker epithelium over an anterior stromal bulge. It can't happen because the epithelium follows the contours. It compensates for the contours. So if the epithelium is thicker in a region of the increased steepening, you've excluded keratoconus as a cause for the inferior steepening. And you can do LASIK on this patient. So let's look at our keratoconus paper itself, and we showed that the more severe the keratoconus, the thinner the thinnest point got, and obviously the thicker the thickest point of the ring got. And we exploited the difference in profiles of the epithelium to try and use it as a screening tool. We developed an algorithm that will take the anatomical difference between the test eye and the normal population and determine how much it looks like a keratoconic epithelial profile. So let's look at some examples. So here's an epithelial thickness in a suspect topography with suspect tomography, and we're using the epithelium to confirm a diagnosis of keratoconus. So here's a case that doesn't look right. It's slightly crab claw shape, although the algorithm doesn't pick it up on the front surface. It says that it's normal. The Bell and Ambrosio, of course, really does pick this up and flags it as red. The D is red. So this, it's a suspect keratoconic case, even though the front surface doesn't look that bad. And you can look at the epithelial profile and you can confirm that there's thinning of the epithelium over the position where the back surface is elevated. So that these two correlate, and that is confirmation of keratoconus. This is a 6 millimeter map from the RT view, and here's a 9 millimeter map showing just that you're not cutting off your donut as much if you look in a 9 millimeter zone. And 9 millimeters, I would say, is the minimum acceptable epithelial maps to be able to do this kind of adequate keratoconus screening work. Here's the ultrasound Artemis. Actually, this is the Insight, the commercially available Insight 100 scanner, showing on the same eye, the very high correlation between the two machines in measurement. The Insight comes along with our automatic classifier, which of course then tells you whether it's likely to be keratoconus or not. So here's another example where epithelial thickness is used to determine whether a borderline topography or tomography is keratoconic. Now this topography looks relatively abnormal, of course, but it's still classified as normal by the front surface. And when you look at the Bell and Ambrosio, the D is only yellow. It's not really a focal back surface change. It could just be cylinder on the back surface. And so this really does look like keratoconus, but again, if you look at the epithelial thickness profile, you can see how nicely this tongue of thinner epithelium surrounded by thicker epithelium matches the back surface Bell and Ambrosio plot. And again, the 9 millimeter map gives you a much better indication of the focal thinning than just a 6 millimeter map, and it gives you the context of the peripheral thickening much better. Here's the same cornea scan with a high-frequency ultrasound, and our classifier, which Ron Silverman and I did at Columbia University, published this in IOVS, and this does actually classify as a keratoconic cornea. Let's look at this case where the topography looks normal, and the Pathfinder finds it to be completely normal, but if you look at forget about the little lights on the Bell and Ambrosio. If you look at the actual Bell and Ambrosio, you could suspect that this might be a very early keratoconic. It's particularly if you look at the back surface elevation on the Bellin-Ambrosio plot in correlation to the fact that the astigmatism on topography have skew axes, and there is asymmetry. It's steeper inferiorly than superiorly. So this starts to make you wonder whether maybe it could be keratoconus. This is where your epithelial map comes in to the rescue of the patient, because the 6mm map shows that the epithelium is thicker inferiorly over where the cornea is steeper, and there is no focal thinning pattern in that epithelium correlating to the back surface abnormality. So on the 9mm map, you see very, very clearly how now your epithelium is basically your safety guarantee that this is not keratoconus, even though the sand's been kicked up a little bit into the air by the Bellin-Ambrosio plot and the fact that the axes are skewed and there's some asymmetry in the astigmatism. So here's an example which can really get us quite worried, because you can have an absolutely normal front surface. This is an axial power, it's a tangential power map. The front surface of the cornea, it's a little bit asymmetric, but it's flat, it's a 42K. There's really nothing to write home about here. The back surface analysis with the Bellin-Ambrosio looks totally normal according to the algorithms there. But when we did an epithelial thickness power map with ultrasound here, we found that there was quite a bit of focal thinning, and the epithelium was basically in a donut pattern, which was characteristic of a keratoconus, but not diagnostic, because it's a big area and it's not like a focal cone. However, when we look at the map down here, we're looking at a pattern deviation map. And this is what we've done with the Insight, is we've taken the population of normals and we can compare this one eye to the whole population and plot the standard deviations away from normal, either thinner or thicker, based on a color scale. And you can see that inferiorly, the epithelium is thinner than expected, and superiorly, it's thicker than expected. So this pattern is inverted, and this is picked up as well by the algorithm, and classifies the epithelium as keratoconic. So here's an example where the front surface and back surfaces might have just allowed us to do the case completely, no problem. But when we actually go to epithelial thickness profiles, and certainly when we look at them statistically compared to normal population, we become aware that this is actually a keratoconic eye. And this patient, who would have easily have had LASIK anywhere without epithelial mapping, is now excluded from having LASIK and ended up with an ICL. So the whole point here is trying to avoid ectasia in cases where the topography is normal. Here are 6 cases I've lined up where everything looked 100% normal on the front surface, but the epithelial profile showed focal thinning with a donut pattern under that front surface, and therefore these were all actually cases of early keratoconus. Likewise, you can have keratoconus flagged up by one of your machines, which makes it extremely worrisome to do the case, even if you think it isn't keratoconus from whatever the history, being stable for 10 years or whatever. But you can use an epithelial map to back this up. And by demonstrating that the epithelium is thicker in the zones where there's increased steepening, by showing that correlation, you are effectively excluding there being keratoconus as a reason for inferior steepening. So this is the case that we find in about more than 80% of the cases where you have suspect keratoconus. They're proven to actually not be keratoconic at all, and we can do LASIK on them. Keratoconus screening by epithelium measured by OCT is now published, and there's more and more papers coming out every year on this. In our study, which we did many, many years ago, about 15 years ago, we took 1,500 consecutive eyes that were coming through our clinic. We screened them with back surface and front surface modalities. When we thought that an eye was suspect, and that was about 9% of the time, we then went and did an Artemis scan. and we measured the epithelium. And of those patients that got epithelium mapped, 84% of the eyes were found to be normal, and 16% were found to actually be keratoconic. So as you can see, effectively, we were confirming the diagnosis of keratoconus where we weren't sure in 1.5%, but we did 7% more surgery than we would have, because in the 9% of cases where we weren't sure, we were able to unequivocally determine that this was not keratoconus by epithelial profiles, and did LASIK with the handcytome, actually, in these days, without inducing ectasia. And we've published the long-term follow-up showing that ectasia wasn't produced in these eyes. So effectively, the impact of epithelial thickness mapping pre-op is very, very high, because it's going to stop you from operating on an eye that looked normal but wasn't. But actually, more frequently, it's going to allow you to do surgery on an eye that looks abnormal but isn't. And that's really, that's where I think that epithelial mapping is going to be totally mainstream. In fact, we have now studies showing that using epithelium to detect keratoconus is actually more sensitive than topography or tomography. So in fact, if you were to only have one machine, it would be one test pre-LASIK, it would actually be an epithelial thickness map. You're more likely to pick up keratoconus than looking at topography. Strange to be saying that 25 years later. The last part of the impact is to do with therapeutic surgery. And in order to talk about this is another 2 or 3 webinars. We run courses every year at the ESCRS and at our clinic in London on the impact. And to understand the diagnostic procedure within a complicated cornea, you have to go layer by layer and understand where the issues are. To understand the optical effects, you have to know the difference between the stromal surface irregularity that you may be wanting to correct and the compensated epithelial profile producing a topography that cannot be used for topography-guided treatment, because it's not the true form of the stromal surface that you're trying to correct. So this is the subject of a whole other area of discussion, and it's really it's where you can, you have the diagnostic power for the unusual event where you have a complication in your practice and you don't know what to do. And for those few times when that happens every year, having the ability to diagnose what's wrong and therefore actually be able to know what to do next can be quite a lifesaver for your practice, because rather than having this patient being told there's nothing that can be done or you have to wear a rigid contact lens, you can actually usually diagnose and manage these patients. So that's something which I hope I can do another time in another webinar. Okay, thank you for your attention.